Welcome back. We are now with Legislative Council. We're going to do a walkthrough of S-126. And do you mind, Jen, if we take questions after each section?
However you want to do it.
Let's do that.
Which one are you gonna do, Jen?
126, S-126,
Probably the
unofficial.
unofficial.
Yeah,
Yeah,
I never use the
yeah.
official one.
The official is the one that has the red C's on it.
All right. Well, good afternoon, Jen Carby from the Office of Legislative Counsel, and we are going to walk through S-126 as passed by the Senate. Got an overview from the chair of Senate Health and Welfare earlier. This is an act relating to healthcare payment and delivery system reform. It starts out with a purpose and goals. It says that the purpose of the act is to promote the transformation of Vermont's healthcare system. And in enacting this legislation, the General Assembly intends to advance the following goals. 1, improvements in health outcomes, quality of care, and regional access to services. 2, an integrated system of care with robust care coordination and increased investments in primary care, home health care, and long-term care. 3, stabilizing healthcare providers, reducing commercial health insurance premiums, and managing hospital costs based on the total cost of care, beginning with reference-based pricing and continuing on to global hospital budgets. And 4, improving population health and increasing access to health insurance coverage. Pause there if there's anything, questions anybody has on it. Right. We get into some sections on hospital budgets and payment reform. Section 2 amends 18 VSA section 9375, which is the duties of the Green Mountain Care Board. And most of what's happening in this section 2 is really just adding into the list of duties of the Green Mountain Care Board so that it lines up with the more substantive changes that come later in the bill. So under existing law, there's a list, the board has the following duties. 1 is to oversee the development and implementation and evaluate the effectiveness of healthcare payment and delivery system reforms. And there's more language there. But part of that is to implement by rule methodologies for achieving payment reform and containing costs that may include the participation of Medicare and Medicaid, and which may include the creation of healthcare professional cost containment targets. And now we've added in reference-based pricing, which you'll see show up a few more times, one in detail. Global payments, bundled payments, global budgets, risk-adjusted capitated payments, or other uniform payment methods. Further in the list of Green Mountain Care Board duties is a duty to set rates for healthcare professionals pursuant to section 9376 to be implemented over time. And this adds beginning with reference-based pricing as soon as practicable, but not later than 2027. Again, the details of what that looks like will come in a later section. I'm just trying to put some conforming changes in here. Number 6 is to approve, modify, or disapprove requests for health insurance rates pursuant to 8 VSA section 4062, which would be changed based on the bill you did on the floor this morning to 4026. That's the renumbering. Taking into consideration the requirements in the underlying statutes, changes in healthcare delivery, changes in payment methods and amounts, and this adds including implementation of reference-based pricing, and then protecting insurer solvency and other issues in the board's discretion. Number 7, just some fairly extensive changes added here. This is in reviewing and establishing hospital budgets pursuant to Chapter 221, Subchapter 7 of Title 18. And this adds including establishing standards for global hospital budgets that reflect the implementation of reference-based pricing and the total cost of care targets determined in collaboration with federal partners and other stakeholders, or as set by the statewide healthcare delivery plan developed pursuant to section 9403 of this title, once established. So recognizing that if there would be total cost of care targets, depending on what kind of federal model, for example, the EdHead model would include total cost of care targets, but that may not be a direction the state is going. So it allows some flexibility there that the total cost of care targets either would be determined in collaboration with federal partners and other stakeholders, or set by the statewide healthcare delivery plan developed pursuant to section 9403 of this title, once established. You'll see that language a lot because toward the end of the bill, it calls for the development of that statewide healthcare delivery plan. And a lot of stuff in the bill is tied to that, but not operable until that plan is established. Beginning not later than hospital fiscal year 2028, the board shall establish global hospital budgets for one or more Vermont hospitals that are not critical access hospitals. And by fiscal year 2030, the board shall establish global hospital budgets for all Vermont hospitals. You'll see that language repeated later as well. So that was section 2. That's the list of board duties and some mainly conforming changes to reflect other things that happen in the bill.
I have a question. We tend to think of the board as hospital budget review, insurer rate review. But all of these other, which are already in statute, 9375, or so the board already has authority to develop, promote, set all of these things for all other areas in our healthcare system, it seems like. Do they have the authority to, I guess I just think of them as authority over hospitals and insurers. But does their authority go beyond that?
I'd say it depends. The language, for example, that is set up in existing law in subsection or subdivision 5 at the top of page 3, setting rates for healthcare professionals. That authority exists but has not been exercised. And some of that is, as I understand it, a resource issue that they would need more staff and expertise to be able to do that. But in that case, that would set the rates that healthcare professionals could accept for their services, and looking at having more uniform or more consistent payment amounts accepted across payers and providers. So yes, they would have some authority. They would need to adopt rules in a lot of cases to actually implement that authority. And some of that has not been done yet.
I'm just thinking about Chair Lyons. I had asked her about the section at the end of section 3, the end of section 3 that had to do with AHS, developing methodologies for reference-based pricing for all other providers. But it seems to me like the board already has the authority to do that.
The board could, so I'm looking at the language. I mean, the language of the bill in that section.
Yes, we get
Yeah.
that. It's really page 6, right? It was on.
It's on page 8. Allows the Agency of Human Services in consultation with the board to implement reference-based pricing for services delivered outside of a hospital. And I think there's some an interest from AHS and others in clarifying which payers are incorporated in that, partly because they already do this for Medicaid, but they don't do it for commercial insurance. So yes, that is some authority that I think arguably exists within the board's existing authority, but as I said, they have not had the capacity to implement it.
Okay. Brian?
So if this is too much of a sidetrack, you can just say it and we'll come back to it, but it has to do with the powers and duties of the board, and like that's what this fits into. One of the concerns that people have brought to me is that they're afraid that, and if anyone on the committee feels this way, feel free to say it for yourself if you're one of the people, but like people have said to me, they're worried about the Green Mountain Care Board getting too much power and about them having too much control of the healthcare system, and specifically about them interfering in the healthcare choices and getting between providers and patients. Or like at the worst, like this whole, I'm going to use a word from the Affordable Care Act era that's very dramatic, but the whole death panel fear, where like people were like, oh, these boards are going to be deciding who lives or dies. Like, what are the statutory limits currently for how much control the Green Mountain Care Board has over the personal health care decisions of people? not counting like the cost of care and stuff, which actually does influence their behavior, but like, and like, does the Green Mountain Care Board have any power to make decisions about what a doctor gives a patient?
I don't believe so.
Okay,
I mean, you know, I'm pulling up,
the point.
well, going back to the language of the bill for a moment, just to look at existing law. You can see. You can see that the lead-in language for the board's duties is that the board shall execute its duties consistent with the principles expressed in section 9371 of this title. That is the Act 48 principles. And so some of those provisions include every Vermonter should be able to choose their own providers. Some of what actually we were talking about earlier with the personal responsibility.
Yeah, there is one about personal responsibility, actually. I forgot how it's worded,
You know,
but
the principles for the framework for the reform of healthcare in Vermont talks about universal access to and coverage for high quality medically necessary healthcare services. Systemic barriers such as cost must not prevent people from accessing necessary care, and all Vermonters must receive affordable and appropriate care, the appropriate time and the appropriate setting. But some of this is just looking to see where some of this language is. Every Vermonter should be able to choose their own providers. They have a personal responsibility to maintain their own health and use health resources wisely. Number 8, the healthcare system must recognize the primacy of the relationship between patients and their healthcare practitioners, respecting the professional judgment of healthcare practitioners and the informed decisions of patients. Continuous improvement.
Number 7 is very interesting.
yeah, can we read that one slowly? Because I think people should hear it. Like,
Sure. Individuals have a personal responsibility to maintain their own health and to use health resources wisely, and all individuals should have a financial stake in the health services they receive.
these are the things underpinning the work of the Green Mountain Care Board. Like, they
Right.
must abide by these.
Yes.
Mhm.
And I know they refer to them a lot. I mean, I've heard them say in their testimony as well that they're guided in their decision-making by the Act 48 principles that are at the beginning of the Green Mountain Care Board chapter. That's where they were codified because they were supposed to apply to their work.
Woody, did you have a question?
Well, I was just thinking about the Green Mountain Care Board and going along with what Brian said. Who oversees what the Green Mountain Care Board does? If all of this bill is enacted, who will oversee the Green Mountain Care Board in ensuring that it's doing all the right things? We talked that you just showed on the board there.
I mean, I think a lot of that, well, there is no, by design, there is no oversight of the board by any entity in state government. They are an independent
Yeah,
board. So
Quasi-judicial,
if people are unhappy, Vermonters are unhappy with the decisions that the board are making, they will probably bring that to you. As legislators, they may bring that to the Office of the Healthcare Advocate to speak on behalf of Vermonters in various regulatory proceedings. But I mean, I think a lot of what you're setting up here, and there's a lot of reporting that you'll see at the end of the bill that's asking the board and the Agency of Human Services, which also has a lot of authority in here, to come back and report on what they're doing.
I'm gonna go with Tucker and then Brian.
Doesn't the governor appoint people?
The governor appoints the members of the board, but does not oversee their work and cannot remove them, and cannot remove
The
them.
the administration, Secretary of Administration reviews the reports
Reviews which reports.
that they have to give at the end of they're supposed to give some kind of report at the end of the year.
I'm not. I mean, they submit an annual report to you, the legislature.
I'm sorry.
Okay.
Does anyone have
Is that what you're talking about?
Yeah.
Okay.
Does
Yes.
anyone have the authority to remove a board member?
I believe their statute says that members may be removed only for cause, and they are supposed to have adopted rules to establish what cause looks like, board membership authority.
That's okay. We don't have to.
Yeah.
Yes, members of the board may only be removed for cause. So I guess I don't know who removes them for cause. The board shall adopt rules pursuant to the Administrative Procedure Act to define the basis and process for removal.
It was related, Topper asked part one of my question, which was confirming the governor appoints them. The other part of my question is, do they have term limits and term times? Or is it?
Those are 6 years. And you worked on some of this
Yes.
last term.
It's more for the record.
Yep. So I can put this language up as well.
And they're nominated by a nominating committee, and that's who the governor must choose from.
From the list given to him by a
On
committee.
the list given, yep.
And it's 6-year terms, and how many
6-year terms. The governor shall not appoint a nominee who is denied confirmation by the Senate within the past 6 years. The
He's done
term
that for some things already.
member is 6 years. An appointment to fill a vacancies for the unexpired portion of the term vacated. A member may serve more than one term, and they may be reappointed to additional terms subject to the requirements of Section 9391, which is what the prior iteration of this committee worked on last biennium, updating some of that. Board members can be removed only for cause. And then there's some conflict of interest provisions.
It would look like the board would monitor its own members, removing for cause by the board.
I believe so, but I really think it really depends with them. And I don't think they could adopt a rule that delegated that authority to somebody else. So I would imagine so, but I don't know what
Yes.
is in, if those rules have been adopted and what is in them.
Because that's specific to the House too.
Let's move on to section 3. We could spend like days. Jen reads us statute.
And maybe we could look at it more as we go if we need to.
Podcast. That sounds like fun.
It could be one of those put you to sleep type.
Yeah.
Let's work on it.
Today, Jen will read.
It's a relaxing
18
sound.
ESA.
Yeah.
We'll read S30 from the beginning. All right, section 3.
Okay.
Rate setting authority. So this is, as I said, much of this is an existing law. And I just put in subsection headings because the section gets very long. But this is the payment amounts and methods. This is the existing Green Mountain Care Board rate setting authority that they have not exercised, but they have authority to exercise. It starts off an existing law with intent about ensuring payments to healthcare professionals are consistent with efficiency, economy, and quality of care. It will permit them to provide on a solvent basis effective and efficient health services that are in public interest. There's the rate setting authority that allows the board to set reasonable rates in order to have a consistent reimbursement amount accepted by these persons. Under existing law, again, there's methodologies, supervision for antitrust purposes. And then we get to the new language in subsection E, and this is the subsection on reference-based pricing. This language directs the board to establish reference-based prices that represent the amounts that health insurers in this state shall pay to hospitals for items provided and services delivered in Vermont. The purposes of reference-based pricing are to contain costs and to move healthcare professionals toward a site-neutral pricing structure, while also allowing the board to differentiate prices among healthcare professionals based on factors such as demographics, population health in a given hospital service area, payer mix, acuity, social risk factors, and a specific healthcare professional's role in Vermont's healthcare system. And just for your informational purposes, the definition of healthcare professional, somewhat confusingly for this chapter, is the very broad definition that includes institutions and facilities as well as individual providers. So when it's talking about a specific healthcare professional's role, it's not necessarily talking about a specific physician or nurse, but it could be the hospital facilities and other facilities as well. It requires the board to consult with health insurers, hospitals, other healthcare professionals as applicable, the Office of the Healthcare Advocate, and the Agency of Human Services on ways to approach reference-based pricing in an effort to achieve all payer alignment on design and implementation of the program. Requires reference-based prices established pursuant to this subsection to be based on a percentage of the Medicare reimbursement rate for the same or a similar item or service. So the reference in this case is to the Medicare reimbursement rate. Provided that after the board establishes initial prices that are referenced to Medicare, the board may opt to update the prices in the future based on a reasonable rate of growth that is separate from Medicare rates, such as the Medicare Economic Index measure of inflation, in order to provide predictability and consistency for healthcare professionals and payers, and to protect against federal funding pressures that may impact Medicare rates in an unpredictable manner. I'll just pause here to say sometimes Medicare rates are affected, just like Medicaid rates may be affected by amounts that are appropriated by the General Assembly. Medicare rates may be affected by dynamics that are playing out at the federal level. This language is to protect against having Vermont's provider rates linked directly to those with no opportunity for modification. In establishing reference-based prices pursuant to this subsection E, the board shall consider the composition of the communities served by the hospital, including the health of the population, demographic characteristics, acuity, payer mix, labor costs, social risk factors, and other factors that may affect the costs of providing care in the hospital service area. Language directs the board to begin implementing reference-based pricing by establishing the amounts that health insurers in this state shall pay to Vermont hospitals for items provided and services delivered to individuals covered by the health insurer's plans as soon as practicable, but not later than hospital fiscal year 2027. The hospital fiscal year runs October through September, so that would be October 2026 through September 2027 is hospital fiscal year 2027.
Alan,
Just I'm trying to get ahead of myself here. The Green Mountain Care Board would be able to implement different prices for reference-based pricing to different hospitals for different services.
Based on, or they could, yes, based on the various dynamics. Yep.
Okay.
All right. So not later than hospital fiscal year 2027, the board shall implement reference-based pricing in a manner that does not allow hospitals to charge or collect from patients any amount in excess of the reference-based amount established by the board for the item provided or service delivered. So this, you heard Senator Lyons say the bill would protect against balance billing. That's what this does. This says the hospitals can't bill the patient for the balance between what the hospital would have charged and what they got reimbursed or would have wanted to get paid and what they actually got paid. The board, in collaboration with the Department of Financial Regulation, shall monitor the implementation of reference-based pricing to ensure that any decreased prices paid to hospitals result in commensurate decreases in health insurance premiums. It requires the board to post its findings about the alignment between price decreases and premium decreases annually on its website. Directs the board to identify factors that would necessitate terminating the use of reference-based pricing in one or more hospitals, such as a reduction in access to or quality of care. And then finally, the language the chair was mentioning earlier, the Agency of Human Services, in consultation with the Green Mountain Care Board, may implement reference-based pricing for services delivered outside hospital, such as primary care services, and may increase or decrease the percentage of Medicare or another benchmark as appropriate, first to enhance access to primary care and later for alignment with the statewide healthcare delivery plan once established.
All right. Do you have a sense of, since your time in Senate Health and Welfare on this, do you have a sense of how much time the committee debated another bill for reference-based pricing that starts with VSEA and Vermont NEA, how much they talked about?
I didn't talk about that bill per se, but they did receive a proposal from the Vermont NEA and VSEA that was asking to have reference-based pricing implemented at set percentages of Medicare beginning January 1st of 2026. And I think there was some concern both from the committee and from the Green Mountain Care Board About whether the rates that were being proposed in those bills were actually the appropriate reference-based prices to be paid, and the impact that that would have on the hospitals if those rates were paid, and potentially on other payers as well to make up the difference. And also just not having a reference-based pricing mechanism stood up and carving up the population before the whole program was ready.
I'm actually wondering, is there anything in this section? There's a lot talking about the way they should develop reference-based pricing. Like I'm looking at 2B. It talks about line 11, page 7, line 11. Talks about, they should take into account the health of the population, demographic, labor costs, social risk factors, other factors that may affect the cost of providing care. And somewhere else in the section, there were more things. Is there anything that limits hospitals that are being impacted by this reference-based pricing to, I guess what I'm wondering, is it a status quo? Is it built on the, what are they calling it? The health resource allocation plan or?
The statewide healthcare delivery.
Yeah, I didn't get one word of that right. Like if you look at, let's take labor costs. Let's just say a hospital can't just give like all the cardiology nurses a huge raise. And then, then the board would have to set the reference-based pricing upon outside factors that were out of their control, or all other factors that can affect the cost of providing care in the hospital service area. I'm thinking if a hospital decides to buy out like all specialty care in, say, like they bought all the dermatology practices, then the board would have to take into consideration their ability to sustain. I'm just wondering if there's guardrails on being able to inflate your costs and that the board wouldn't have any ability to actually change.
I think the work the board does with the hospital budget review is already, I would defer entirely to the board to tell you what their processes look like, but my understanding is that they have a reasonably good sense for what things cost, and what the hospitals spend their money, how they spend their money now, that would inform the way they would be developing the reference-based prices. But I think it will be important to hear from the board on how they envision rolling this out. It won't be the first time they've thought about it. They've certainly been thinking about this topic for a while and have been working on it with the Senate for a while.
Okay, but there's nothing in this section around setting reference-based pricing, not on the services that are being provided now, but the services that we want to be provided.
I think some of that, certainly for the non-hospital prices, particularly around primary care and potentially later in other areas, yes, definitely was talking about increasing or decreasing the percentage to enhance access to certain types of care. So I think that is being contemplated once this is up and running, to be able to use the reference-based pricing in part and to press down, up or down on types of care that the healthcare system determines should be incentivized or decentivized.
There's also a section, Jen, you will know where it is better than I could remember, but in the development of the state healthcare delivery plan, it was spelled out what those services and measures
Yeah, I think, right, I think there are, yes,
they had to cover in the development of that plan.
that then will feed into this
Yeah.
language here. Yeah, and I think,
That's what I'm wondering. That's kind of what I'm thinking is,
yes, I think the vision is for the reference-based pricing to be used as a tool not only to contain costs and cost growth, but also to be able to encourage and discourage types of care that are may have more value to the system as far as preventing more, upstream services that can reduce acuity.
thank you.
Right, sections 4 and 5 really kind of go together around hospital budget review. So section 4 is the hospital duties side of hospital budget review and information that the hospitals must file with the board. And this adds some new items. One is the number of employees of the hospital whose duties are primarily administrative in nature, as defined by the board, and the number of employees whose duties primarily involve delivering healthcare services directly to hospital patients. Also, information regarding base salaries and total compensation for the hospital's executive and clinical leadership and for its employees who deliver healthcare services directly to hospital patients. And then proposals for ways in which the hospital can support community-based, independent, and non-hospital providers, including mental health and substance use disorder treatment providers, primary care providers, long-term care providers, and physical therapists, services provided through the Blueprint, Choices for Care, and SASH, investments in the healthcare workforce, and other non-hospital aspects of Vermont's health and human services systems that affect population health outcomes, including the social drivers of health. And then the final and anything else the board requires. And then in subsection B, this is something Senator Lyons had referred to. This will require hospitals to submit information as directed by the board in order to maximize hospital budget data standardization and allow the board to make direct comparisons of hospital expenses across the healthcare system. So allow for more apples to apples comparison from hospital to hospital so that they are reporting the same kinds of information in the same ways. There's a question.
Oh, Leslie, sorry.
Talk or two. So I'm looking at 9, proposals for ways in which hospitals can support community, blah, 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 blah. That to me is soft. I mean, the proposal could be, offer something to 10 people or to offer something to whole population. So are we going to hear, I guess the point is I want to hear from the Green Mountain Care Board of what would be an acceptable proposal. What does that mean?
Did you use the word soft? Is that what you said? Okay.
It's not, I don't know what the expectation is.
Yeah.
Just by that language yet.
So you're saying essentially that we're not telling them that they must.
Well, this
They can come up with proposals.
it seems like the Green Mountain Care Board is asking the hospitals for proposals.
Yeah.
That's my interpretation, but that could be across the board in any which way. And I'm wondering about something more solid.
It's a good question for the board.
Yeah.
Tucker.
That was my question, but I'm trying to figure out in what ways now it can do that.
Right, that's the point.
Yeah.
So that's my question. Like, what are we asking them to do? What would fit in?
What are we looking for here is what you want to ask them?
Yeah.
I think that's fair. I think this concept had originally been in the next section, which is what the board must do as part of establishing hospital budgets. And it was supposed to tell them ways to support these providers and other services. And the board was concerned about having to come up with what those look like and wanted the hospitals to propose them. And then the board could incorporate what the board thought was appropriate into the budget orders.
But talking about guardrails.
Right, but
Yeah.
I think having a conversation with the board about what that looks like to them and what their expectations are and whether that will be fleshed out more in hospital budget guidance I think it's appropriate.
Is the intent of line 13 where it says investments in the healthcare workforce? Is that like workforce development or
Could be
just
workforce development, it could be,
in the healthcare workforce anywhere
they're
or
just
just non-hospital?
proposals.
Okay.
Examples, I guess.
Yes,
It says, and other non-hospital aspects.
yes, I think definitely, investments in the pipeline, investments in upskilling. I mean, there are lots of ways to invest.
This was sort of a workforce development idea.
That one line,
Yeah,
part of,
okay.
yes, that half of 13.
It was just, thank you.
Yes, workforce development, workforce retention. I mean, I think there's a lot of areas of potential. Section 5 is the budget review statute itself. And so this makes a number of changes to what the board is to do in healthcare and hospital budget review. First, in conjunction with budget reviews, the board would, new number 2, consider the statewide healthcare delivery plan developed pursuant to section 9403, again, once established, including the total cost of care targets, and consult with the Agency of Human Services to ensure compliance with federal requirements regarding Medicare and Medicaid. And some renumbering, and then a new number 6. For a hospital that operates within a hospital network, review the hospital network's financial operations as they relate to the budget of the individual hospital. New number 7, exclude revenue derived from primary care, mental health, and substance use disorder treatment services when determining a hospital's net patient revenue and any total cost of care targets. So to incentivize more spending in those areas as opposed to others.
Go back to 6. So are what they saying that, so we're adding that they can review the hospital network's financial operations, but only as they relate to, oh, okay,
This is in hospital budget review, so this is specific to hospital budgets.
okay.
Um,
Yeah, go ahead.
So where is the hospital to get its revenue if it can't get it from, primary care or mental health?
Oh, it's not saying they can't get it from there. It's saying when determining a hospital's net patient revenue and any total cost of care targets, anything that the hospital is going to be potentially held accountable for as a cap, it would not include those types of care that would be encouraged because they would be encouraged. So I believe from my fairly limited understanding of hospital budgets and hospital budget review, this is a good thing if you're supportive of primary care, mental health and substance use disorder treatment service. All right, and then just some renumbering until number, what is now 16. Consider the salaries for the hospital's executive and clinical leadership as adds, including variable payments and incentive plans. And then existing language and hospital salary spread, including a comparison of median salaries to the medians of Northern New England states. And then adding, and a comparison of the base salaries and total compensation for the hospital's executive and clinic leadership with those of the hospital's lowest paid employees who deliver healthcare services directly to patients, to hospital patients, and consider the number of employees of the hospital whose duties are primarily administrative in nature as defined by the board compared with the number of employees whose duties primarily involve delivering healthcare services directly to hospital patients.
I know it's already in statute, but Northern New England states, is there a definition of who's northern? What is that, just Maine, New Hampshire?
Maine, New
Vermont?
Hampshire, Vermont, yes. Then we get into southern New England.
What's that?
We get into southern New England.
Southern New England, the south.
All right, then we have subsection C, individual hospital budgets established under this section must, or shall. And number 1 is be consistent. This adds to the extent practicable because we're adding with the statewide healthcare delivery plan once established including the total cost of care targets and with the health resource allocation plan. These adds reflect the reference-based prices established by the board, and then some renumbering till we get down to new number 8. Include meaningful variable payments and incentive plans for hospitals that are consistent with this section and with the principles for healthcare reform expressed in section 9371 that we were looking at before. Then in subsection D, under existing law, annually, the board establishes a budget for each hospital on or before September 15th, followed by a written decision by October 1st. And each hospital must operate within the budget established under this section. New language, beginning not later than hospital fiscal year 2028, the board shall establish global hospital budgets for one or more Vermont hospitals that are not critical access hospitals. And not later than hospital fiscal year 2030, the board shall establish global hospital budgets for all Vermont hospitals. Global hospital budgets established pursuant to this section shall include Medicare to the extent permitted under federal law, but shall not include Medicaid. And I will defer to the board and AHS to explain those provisions to you. Language I was directed to put in, but I can't say I can articulate the info. In E, this requires the board in consultation with the Vermont Program for Quality in Healthcare to utilize mechanisms to measure hospital costs, quality, and access and alignment with the statewide healthcare delivery plan once established. Except as provided in subdivision D, which we'll see in a minute, a hospital that proposes to reduce or eliminate any service in order to comply with a budget established under this section shall provide a notice of intent to the board, the Agency of Human Services, the Office of the Healthcare Advocate, and the members of the General Assembly who represent the hospital service area, not less than 90 days prior to the proposed reduction or elimination. This is the idea of the reverse CON, but this is really what it actually looks like. The notice shall explain the rationale for the proposed reduction or elimination and describe how it is consistent with the statewide healthcare delivery plan once established, and the hospital's most recent community health needs assessment conducted pursuant to state and federal law. And that's a requirement for nonprofit hospitals, which all of Vermont's hospitals are. The board may evaluate the proposed reduction or elimination for consistency with the statewide healthcare delivery plan once established and the community health needs assessment, and may modify the hospital's budget or take such additional actions as the board deems appropriate to preserve access to necessary services. And then the exception here in D is that a service that has been identified for reduction or elimination in connection with the transformation efforts undertaken by the board and AHS pursuant to Act 167 does not need to comply with those notice requirements.
That's interesting.
This is all after the implementation of global hospital budgets by
No, this is
2030.
separate. No, this
This
is
is separate.
separate.
Okay. Topper and then Woody.
What do you
Let's say this,
Okay, go ahead.
this seems like deja vu. It seems like the dialysis
That's why this is in
issue
here.
and some
Yep.
other things.
That's exactly why this is in here, so that you would not, and that's why I looked at a couple of other states that have provisions around this, and one of them required notice to the legislative delegation, which is why I put the language in there, required notice to the General Assembly as well, and then at least 90 days so that their action can be taken if needed before services are discontinued.
And the same way with the trustees voting themselves a pay raise and bonuses, things like that. It seemed like there
I
was
think
something
that's
similar.
Different, but that'll be coming, I mean, yes, in that instance, I think the timing
Yeah.
was all near to one another. Although, I think different parties making decisions.
Sorry, I'm just noticing the snow.
Oh, no.
Topper, did you have a question?
It's like,
Well, it's more of a statement. There's a lot of verbiage in here about the Green Mountain Care Board looking at salaries in northern New England, et cetera, costs and so on. I am sure that the hospitals as they exist today, as we sit in the room, have already said, in order for us to have a CEO or administrative person, we have to pay X amount of dollars. So when we limit it now to northern New England, which is the 3 states, their salaries are already up there, what was in Massachusetts and not southern New England.
Well, that language is existing law about the hospital's salary spread and the comparison with other northern New England states.
Yeah.
You can certainly broaden it. I think it might be helpful to know from the board whether they look beyond northern New England.
If they're trying to control costs, they're already up there. That's how I look at it.
This is just them, though. These are things that they may consider.
In establishing the hospital budget.
Good thing it says may. It also says it may modify.
Did you have another question?
No, I'm just listening to Topper.
It's melodic, isn't it? It's- Leslie, is that your hand up or are you just, okay?
I'm interested in D and how that was come to. I don't expect you to answer that, but maybe at some point, why that is my curiosity.
Why the
Yeah, why?
exclusion?
Yeah, why?
My recollection was that, and you'll hear about it from other witnesses, I'm sure, but that if a hospital is reducing or eliminating a service because that is part of the work that they've been doing with the board and the Agency of Human Services, and that's a decision that's been made as part of that transformation effort, then there wasn't the need for notification to the board or the agency. Healthcare Advocates Office would like the ARB be aware of it. Members of the General Assembly may be as well, but that there didn't need to be notice and an evaluation if it had already been deemed by part of the transformation work that was an appropriate change.
Okay.
So this committee can change that.
I think there's as I look at this thing, there's a lot of maze in there. And whenever I see that, it means he probably won't do it. And where it says here, the board may evaluate, blah, 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 the reduction or elimination, it says it may.
Yes, I think it was a shall for a while and then it became a may.
That's what I'm looking at, because, I mean,
As I recall, and I won't, I can certainly be corrected, but I think that board didn't want to have to review that, didn't want to have to do that every time for any reduction or elimination if it didn't seem like that it merited evaluation for consistency with the statewide healthcare delivery plan and community health needs assessment and other
my question, Jen, then to myself is, this is only me. Why do I even review it? If the statewide healthcare delivery plan has gone through this assessment process, what the needs are, et cetera, then it says, well, they may not do what it says. Why do it? That's only my observation.
Right. I think the plan itself is not as specific as what all of these different types of services are. So
It has to be, it seems to be linked now to the resource allocation plan, the health resource allocation plan. So if you're allocating money for certain things, maybe that's why it says may.
the health resource allocation plan is one of the many plans and other documents that informs the development of the statewide healthcare delivery plan. But I will defer to the board to tell you why they wanted, I believe they wanted the may, why they wanted the may.
Right, I have it noted. Shall the may be a shall?
Yes, it changed. In draft 2.1, we changed from shall to may. It was 3.2, I think, that was voted out. So yes, somewhere along the way, it did change from may shall to may. All right, and then subdivision 3, the board in collaboration with the Department of Financial Regulation is supposed to monitor the implementation of any authorized decrease in hospital services to determine its benefits to Vermonters or the healthcare system or both. Section 6 is the additional language on hospital networks and their financial operations. So as used in the section, hospital network is the same definition as in, is it H482? So a system comprising 2 or more affiliated hospitals and may include other healthcare professionals and facilities that derives 50% or more of its operating revenue at the consolidated network level from Vermont hospitals, and in which the affiliated hospitals deliver healthcare services in a coordinated manner using an integrated financial and governance structure. So that looks familiar. Then it says the board may review and evaluate the structure of a hospital network to determine, 1, whether any network operations should be organized and operated out of a hospital instead of at the network, and 2, whether the existence and operation of a network provides value to Vermonters, is in the public interest, and is consistent with the principles for healthcare reform expressed in section 9371 of this title and with the statewide healthcare delivery plan once established. It says that in order to protect the public interest, the board may, on its own initiative, investigate the financial operations of a hospital network, including compensation of the network's employees and executive leadership. And in subsection D, the board may recommend or take appropriate action as necessary to correct any aspect of the structure of a hospital network or its financial operations that are inconsistent with the principles for healthcare reform expressed in section 9371 or the statewide healthcare delivery plan once established. And finally, any final action, order, or other determination by the board under this section shall be subject to appeal in accordance with the provisions of section 9381, which is the general Green Mountain Care Board appeal statute.
So first of all, we're saying that they may recommend, or they may.
May recommend or
May
take.
review.
Or even review. They don't even have to review if they don't want to review, right?
Yes, this is giving them authority they do not currently have.
And
That's an interesting point.
And we've set out consistency over hospitals, what they must submit to the board within their hospital review, but we don't set out that a network must provide the same financial information, just these 2 instances of like, how much does CEO make? Am I right in that?
There is less specificity here than there is for hospital budget review. But again, this will be the first time that the board is reviewing any financial operations of a hospital network. So it may need to come back and ask for additional language or information in the future. But this will allow the board to begin reviewing and evaluating the structure of a hospital network and its financial operations.
When we get into section 8, statewide healthcare delivery plan, we'll see how strong that is.
Yeah, I know. We're almost there.
But nothing in this, and this is a whole new section as far, I mean, a whole new chapter section. Nothing in here, there's no authority to actually do anything.
There is authority. The board may recommend or take appropriate action as necessary to correct in subsection D any aspect of the structure of the network or its financial operations that are inconsistent with the principles for healthcare reform or the statewide healthcare delivery plan.
And does that open it up to they can take any action that is deemed appropriate at all?
That's what the language currently says. It may make sense to be more specific. I think you may hear varying perspectives on that.
I saw Leslie.
This is sort of a more general idea, because when you said this is new authority for the Green Mountain Care Board, it was like boing. And so the reference-based pricing is new authority too. And I'd be interested in sort of understanding, is everything underlying new authority? Not necessarily, right? Or how would I think about that? Is what's new for the board and what's not, I guess.
Everything underlined is new. language.
New language, but new authority.
Sometimes it's, I mean, if it's,
It may or may not be something that's
Like a,
present now.
well,
How
like
much is embedded in
reference-based
their
pricing
process?
is potentially within their existing rate setting authority, although not necessarily the way it's laid out in the bill currently, which is that it's telling insurers what to pay as opposed to telling providers what to accept. Their existing rate setting authority is really directed more at the provider, the amounts that providers accept. But the concept of the board doing some rate setting is not new, but it has not been exercised.
So wouldn't that pertain to this section that we're now creating, which is we're kind of laying a framework and then 10 years from now, somebody's gonna have to come back and put in what you should be doing?
It's really up to the committee to decide what you would like to tell them to do.
Okay, well, no, I'm just, I guess I thought that there was, but it seems like it's the same framework of what we currently have in statute regarding. Okay, anyways, did anyone have other questions? Oh, yeah, Woody.
Could the Green Mountain Care Board fine a hospital?
Can they fine a hospital?
Yes.
I mean, if the hospital is.
Technically, a monetary fine.
Yeah, I mean, in the hospital and budget enforcement provisions, there are fines for hospitals.
That's already in statute.
Right, who are out of compliance.
And can a hospital leave? Get out from under the Green Mountain Care Board over time being overseen? Can it become private? Could a hospital,
They are private,
well, they're nonprofit supposedly, right?
right, but that's
But could it
different from
just,
being private. They are private. They're not public. They're not run by the state. They're not for profit. Could they transform to become for profit? I mean, there's some,
is there a way for them to do that?
there's a whole statute on conversion of nonprofit hospital. So yes, but I don't know what that would look like, but it still involves the board and we could still regulate them. Their being nonprofit does not affect the state's ability to regulate them.
So there's no
The
way,
Green Mountain Care Board would decide if they can be profit or not.
so there's no way out.
Not if you're going to run a hospital in this state. Otherwise, they would all.
A long time ago. Okay.
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 Yep.
Right, we get on to section 7, which is in part of Title 18 on contracts. These are contracts typically between health insurers and other private payers and healthcare providers. And so this strikes some language that, excuse me, some specific requirements in another subdivision do not prohibit a contracting entity from requiring a reasonable confidentiality agreement between the provider and the contracting entity regarding the terms of the proposed healthcare contract. Instead would say a contracting entity, so that's the payer or their representative, so a health insurer or somebody who is doing the negotiating on their behalf. Contracting entity or provider shall provide an unredacted copy of an executed or proposed healthcare contract to the Green Mountain Care, to the Department of Financial Regulation or the Green Mountain Care Board or both. So this would require, in the interest by the chair of the committee and the health and welfare in particular, is in having DFR and the Green Mountain Care Board be able to have some insight into what the actual terms of a contract between a payer and a provider entail.
But not public access, just those two.
Right.
Okay, sorry, Mari.
I think you said this, but just to be clear, this is only this underlined statement is only referring to insurance contracts. It's not relating to other entities that may contract to provide services for hospitals, for example. This is only talking about insurance.
I believe this is between the payers and the providers, but not public payers, so private payers and individual providers and institutional providers. I feel like I'm not answering your question, so try to.
I'm imagining something much broader that I think this doesn't relate to, like a back to dialysis, if a hospital contracts to have a private company like Fresenius.
Gotcha. No,
This-
this is really payers and providers, private payers and providers, right? So it's also not looking at traveling nurse contracts or any of that. It's really the payment for services.
These statutes refer to, do they include also like ERISA or
Self-funded.
self-funded
To the
PAs?
extent permitted under federal law, which typically means at least the state employees and, although we'd have access to that anyway, state employees and teachers. But no, we can't, I mean, generally, we are preempted from requiring anything of them. But it may depend on how they're organized and what the actual language used said. All right, we're up to the statewide healthcare delivery plan. So, section
You know
8.
so much about it.
This directs the Agency of Human Services in collaboration with the Green Mountain Care Board, Department of Financial Regulation, EPQHC, Office of the Healthcare Advocate, Healthcare Delivery Advisory Committee, which you'll see in the next section, and other interested stakeholders. So the agency shall lead development of an integrated statewide healthcare delivery plan as set forth in this section. The plan shall do a number of things. Number one, align with the principles for healthcare reform expressed in section 9371. Number two, promote access to high quality, cost-effective acute care, primary care, chronic care, long-term care, and hospital-based, independent, and community-based services across Vermont. Third, strive to make mental health services, substance use disorders treatment services, emergency medical services, non-emergency medical services, and non-medical services and supports available in each region of Vermont. Number four, provide annual targets for the total cost of care. So here's the total cost of care targets across Vermont's healthcare system, and include reasonable annual cost growth rates while excluding from hospital total cost of care targets all revenue derived from a hospital's investments in primary care, mental health care, and substance use disorder treatment services. That's that piece again. Using these total cost of care targets, the plan shall identify appropriate allocations of healthcare resources and services across the state that balance quality, access, and cost containment. The plan shall also establish targets for the percentages of overall healthcare spending that should reflect spending on primary care services, including mental health services, and preventive care services, which targets shall be aligned with the total cost of care targets. Number five, build on data and information from various sources, the transformation planning resulting from Act 167, the expenditure analysis and healthcare spending estimate developed pursuant to statute, the state health improvement plan adopted pursuant to statute, the health resource allocation plan, HRAP, published by the Green Mountain Care Board in accordance with statute, hospitals' community health needs assessments and strategic planning conducted in accordance with statute, hospital and ambulatory surgical center quality information published by the Department of Health pursuant to statute, the statewide quality assurance program maintained by BPQHC pursuant to statute, and such additional sources of data information as the board, agency, and department deem appropriate. That language needs a little tweaking because it's left over from an earlier draft.
Daisy has a question.
Back up a ways that you, we're talking about total cost of care. That's for across Vermont's healthcare system. Am I interpreting this correctly that it would require us to do rate studies basically across every provider type?
I don't know. I don't know what it looks like
Okay.
operationalized. It's a good question, but I don't know what it looks like. All right, like continuing on with the plan shall, number 6, identify gaps in care as well as circumstances in which service closures or consolidations could result in improvements in quality, access, and affordability, opportunities to reduce administrative burdens such as complexities in contracting and payment terms and duplicative quality reporting requirements, and federal, state, and other barriers to achieving the plan's goals, and to the extent feasible, how those barriers can be removed or mitigated. It directs the Green Mountain Care Board to contribute data and expertise related to its regulatory duties and its Act 167 efforts, and the Agency of Human Services to contribute data and expertise related to its role as the state Medicaid agency, its work with community-based providers, and its Act 167 efforts. From 2025 through 2027, so here's the timeline, the Agency of Human Services shall engage with stakeholders, collect and analyze data, gather information obtained through the processes established in Act 167, and solicit input from the public. In 2028, the agency will prepare the plan, and by January 15th, 2029, the agency will present the plan to this committee, the committee down the hall, and the Senate Health and Welfare Committee. And the agency shall prepare an updated plan every 3 years and present it to the General Assembly on or before January 15th, every third year after 2029. And that is the statewide healthcare delivery plan.
Leslie and then Topper?
So I'm just wondering about enforcement of the plan. Is that something that happens later or is it just, we're assuming that AHS is going to do it, or how does that happen?
I think we're assuming AHS is going to do the plan. Yes.
Who implements?
Well, a lot of what's in the plan is, I think implementing the plan is more about what's in the rest of the bill and the rest of legislation
That's gonna
between
come
now and then.
Okay.
I
Because
think the plan is what it looks like, and how to put it, the language is sort of how to put it together, what goes into it. But what comes out of it, I think remains to be seen, except for where it's been incorporated into other parts of the law in the bill.
Topper?
Are there any consequences anywhere, Jen? For instance, that sentence shall prepare an updated plan every 3 years. Are there any consequences for not doing any of this stuff in here?
I mean, generally, no. It's usually, you bring them in and you ask them why they haven't done it and how it's going, and if there need to be changes are made. Whether there would be legal action to be taken to force them to do it. I mean, it, comes up from time to time when certain reports or other actions aren't taken. That's discussed, but I don't think it's generally happened.
Yeah, I'm familiar with another plan that was 5 years late, I think, in being redone. It just got done this year. And it raised hell with the people that plan affected. And there's no consequence.
I mean, there's nothing in here. There's no penalty in here if the agency fails to complete the plan in the allotted time. I don't think that's something we typically do to your co-equal branches of government, but we can certainly discuss if there are concerns.
That was going to be my question. Is there any examples of when the plan isn't done? Who gets held accountable?
I mean, the head of the agency that's supposed to do it is typically the one, but I would say it's largely more sort of the court of public opinion, more so than the courts of law.
Woody, did you have a question or?
Okay. Just muttering over
Just
this.
When I saw Leslie's hand, I thought I saw it.
Sorry, I didn't realize.
Let's move on to section 9.
Section 9 is the Healthcare Delivery Advisory Committee, and this is the committee that the Chair of Health and Welfare described as being based on the Rural Healthcare Task Force. Yes, in the sense that many of the same, we did use that after it was recommended as a way to identify many of the parties who would need to be at the table, although some modifications have been made as well. So the purpose of the committee is to establish affordability benchmarks, including for affordability of commercial health insurance, evaluate and monitor the performance of Vermont's healthcare system and its impacts on population health outcomes, collaborate with the Green Mountain Care Board, AHS, Department of Financial Regulation, and other interested stakeholders in development and maintenance of the statewide healthcare delivery plan. Again, there may need to be a few tweaks to some of these. As I was reading through after the bill passed, I realized a few of the changes made to other parts, like having the AHS be in charge of the plan, weren't sufficiently carried through to some of these other pieces. So it's really mostly about collaborating with the agency. Advise the Green Mountain Care Board on the design and implementation of an ongoing evaluation process to continuously monitor current performance in the healthcare delivery system and provide coordinated and consensus recommendations to the General Assembly on issues related to healthcare delivery and population health. This piece is hopefully can make your lives easier if you're getting some more kind of consensus and streamlined recommendations on behalf of a larger group of stakeholders. So here's the advisory committee. There's 14 members. We have the Secretary of Human Services or designee, Chair of the Green Mountain Care Board or designee, Chief Healthcare Advocate or designee, one representative of commercial health insurers offering major medical health insurance plans in Vermont, selected by the Commissioner of DFR, two representatives of Vermont hospitals, selected by VAHS, who shall represent hospitals that are located in different regions of the state and that face different levels of financial stability. One representative of Vermont's federally qualified health centers, selected by State Primary Care Association. One representative of independent physician practices, selected jointly by the Vermont Medical Society and Health First. One representative of Vermont's free clinic program, selected by Vermont's free and referral clinics. One representative of Vermont's designated and specialized service agencies, selected by Vermont Care Partners. One preferred provider from outside the designated and specialized service agency system, selected by the Commissioner of Health. One Vermont licensed mental health professional from an independent practice, selected by the Commissioner of Mental Health. One representative of Vermont's home health agencies, selected jointly by the VNAs of Vermont and Bayada Home Health Care. And one representative of long-term care facilities, selected by the Vermont Healthcare Association. The Secretary of Human Services or designee will chair the committee, and the Agency of Human Services will provide administrative and technical assistance. Keep going.
Any questions on all those people?
Data integration and data sharing, section 10. It has a new section added in Title 18 in the chapter on health information technology and telehealth. This is on integration of healthcare data. Directs the Agency of Human Services to collaborate with the Health Information Exchange Steering Committee in the development of an integrated system of clinical and claims data in order to improve patient, provider, and payer access to relevant information and reduce administrative burdens on providers. Requires the agency's process to align with the statewide health information technology plan established pursuant to section 9351. Use the expertise of the Health Information Exchange Steering Committee, incorporate appropriate privacy and security standards, determine how best to integrate clinical data, claims data, and data regarding social drivers of health and health-related social needs, ensure interoperability among contributing data sources and applications to enable a unified health data space that is usable by all stakeholders, identify the resources necessary to complete data linkages for clinical and research usage, establish a timeline for setup and access to the integrated system, develop and implement a system that ensures rapid access for patients, providers, and payers, and identify additional opportunities for future development, including incorporating new data types and larger populations. Requires health insurers to provide clinical and claims data to the Agency of Human Services as directed by the agency in order to facilitate the integrated system of clinical and claims data as set forth in this section. And it directs the agency to provide access to data to state agencies and healthcare providers as needed to support the goals of the statewide healthcare delivery plan, once established, to the extent permitted by the data use agreements in place for each data set. On or before January 15th annually, AHS would provide an update to this committee, the committee down the hall, and Senate Health and Welfare on the development and implementation of the integrated system of clinical and claims data in accordance with this section. You're gonna need to take some testimony. in this section.
Can I just ask mine really quickly, just because this envisions like a whole new system that information is fed into one centralized system. This is not about interoperability between systems.
I'm gonna defer to the health IT experts.
Okay, excellent.
What's happening here?
Topper and then Mari.
Yeah.
We're getting granular here. I can't do
Page
it.
22, line 12.
Page 22.
Let me see if I can find
Am
it.
I on the wrong, but
Are you back on 22?
Yeah, well, it went so fast, I couldn't get it.
I didn't have a lot of commentary to add in this.
Page 22, here I am. Line 12. Yeah.
22, page 22 is back in the previous section.
Provide, it says here, provide coordinated
Oh, yeah.
and consensus recommendations to the General Assembly, et cetera, et cetera. Now, my question is, I know consensus is nice to get to. Sometimes you can't. It doesn't say if you can't get the consensus, then a majority will rule.
I think, I mean, so I think there has been a lot of work done by a number of these stakeholders to come together and at various times over the last several years to bring you recommendations that represent the viewpoints of their various organizations. And this is saying to the extent they're getting together to work on this stuff and they can come up with some coordinated and consensus recommendations, bring those. That's helpful. I think the way it actually works and whether if 13 out of 14 agree with something and one doesn't, they bring it forward or they don't bring it forward. I think we leave up to that group to decide. Their recommendations may look somewhat like your old budget memos used to look, where it said a majority of the committee or 9 out of 11 members of the committee recommend, and they can do that as well. But it's not. I think it's really looking for an opportunity for you to receive some coordinated and consensus recommendations where possible. I'm thinking particularly around some of what you got during COVID when the provider coalition came together and said, here's what we want from you. And I think it streamlined the work of the committees.
Yeah, and that was in an emergency. Consensus sometimes is easy to get.
It's true, although I think you have gotten
This is
some
the
consensus, not most of your people are here anymore, but I think you have gotten some of your usual folks, some consensus recommendations from provider groups. Sometimes the providers and the payers get together and, so.
Well, they do a wonderful job most of the time.
So if it doesn't work, it doesn't work.
It's a big deal.
Anything else on this or the data integration?
Mari, you have a question, but I'm thinking it's not on page 22. Are we back
Page
into?
25,
All right,
line 13.
okay.
Does
Our
this,
health insurance defined in 9402.
no, does this bump into GoBay versus Liberty Mutual in any way?
Only to the extent that, no, because we're limited in what we can require health insurers to provide. So it is the broader definition of health insurer, but it is the definition that also says, and to the extent permitted by federal law, third-party administrators. So if we are not permitted by federal law because of ERISA preemption, then they don't have to report.
So we couldn't get that clinical and claims data from self-insured hospitals
We cannot require hospitals.
or self-insured businesses that are self-insured that are under ERISA.
It means we can't require it.
We can ask for
We
it.
can ask for it.
Since we're in there, health insurers should provide clinical and claims data. What clinical data do they have?
Answer that. I think they have more than just claims data, so. All right, section 11, are we ready for section 11?
We're ready.
Right. This is amending the board statute, actually the same board, Green Mountain Care Board statute where we were looking earlier on the website at the term length and appointment, but this is something different. This is under the board's existing authority to issue subpoenas, examine persons, administer oaths, and require production of papers and records. This adds a new subdivision 3 that allows the board to share any information, papers, or records it receives pursuant to a subpoena or notice to produce issued under this section with another state agency as appropriate to the work of that agency, as long as the receiving agency agrees to maintain the confidentiality of any information, papers, or records that are exempt from public inspection and copying under the Public Records Act. Was a request from the board, so I will defer to any questions of why. I can tell you what, but I can't tell you what.
Can I make a surprise announcement to everybody? Because I haven't told anyone except for my own head this. Sorry. Yes, say something like that. So we had Jen on the schedule for markup on S28, but it is getting late. And I know we have Jen coming back because there might be some other things Thursday afternoon. So let's move S28 completely to after the floor, and maybe we can get Nolan in after this today, and then we'll be done. Because I know it's getting hot in here.
Gotten hot. Get it?
I know it's
melting over
there.
I'm dying.
No, I'm not pregnant. Jen, can you keep going before things get
Yes.
worse?
Retaining accountable care organization capabilities. This language, and again, needs a little refining in the heading here. The Agency of Human Services, in fact, shall explore opportunities to retain capabilities developed by or on behalf of a certified accountable care organization that were funded in whole or in part using state or federal monies, or both, and that have the potential to make beneficial contributions to Vermont's healthcare system, such as capabilities related to comprehensive payment reform and quality data measurement and reporting. On or before November 1st of this year, the agency will report its findings and recommendations to the Health Reform Oversight Committee. This language is recognizing that Care Vermont is winding down its business by the end of the year, and has developed some capabilities that if the state were able to keep them would be helpful, and we paid for them in whole or in part. So it's directing AHS to look for opportunities to do so before they go away. Then we have a number of implementation updates. Section 13. So this is a little funny, but this is how it worked out. We have sort of one time and then ongoing. So on or before November 15th of this year, the Agency of Human Services will provide an update to the Health Reform Oversight Committee about its implementation of this act, including the status of its efforts to develop the statewide health care and delivery plan, advance healthcare data integration, and explore opportunities to retain ACO capabilities, as well as on its hospital transformation activities pursuant to Act 167, and the effects of these efforts and activities on Vermonters and on Vermont's healthcare system. You'll see that phrase a lot. Section 14 has the Green Mountain Care Board reporting by February 15th, 2026, providing an update to this committee and Senate Health and Welfare on the board's implementation of this act, including the status of its efforts to establish methodologies for and begin implementation of reference-based pricing and development of global hospital budgets, and the effects of these efforts and activities on Vermonters and on Vermont's healthcare system. So those are the first reports, and then we codify ongoing reports. So in section 15, this is adding to an existing statute in Title III around healthcare reform being located in the Agency of Human Services that requires on or before February 15th annually, the Agency of Human Services to provide an update to this committee and Senate Health and Welfare on the status of its efforts to develop and maintain the statewide healthcare delivery plan, advance healthcare data integration, and coordinate hospital transformation activities pursuant to Act 167, and the effects of those efforts and activities on Vermonters and on Vermont's healthcare system. Section 16.
Can I ask
Yes, of course. Sorry, I didn't see her.
does it say when the first one is due?
First what?
Report. So it says on or before, I'm just looking at sections 15, on or before February 15th.
Yes, that's why there's the first one in section 13, they're reporting in November of 2026.
Okay, so
And
this
then in
is,
the effective date, it's when we'll start doing that, the annual.
got it, thank you.
Um,
No, that's the same thing.
And I will say there is the potential to combine these more, but a lot of this was happening on
Yeah, yeah.
final markup and vote day. Otherwise known as crossover. And then section 16 is adding to the Green Mountain Care Board annual report. Again, a requirement for to report on the status of the board's efforts to establish methodologies for and begin implementation of reference-based pricing and development of global hospital budgets and the effects of those efforts and activities on Vermonters and on Vermont's healthcare system. Now, before the bill went to appropriations, it had some positions and some money in it. So I think those may still be reflected in Nolan's fiscal note as needs that go with the bill, even though they are not currently provided for in here. But they are, I think, being considered in the context of the budget, and I'll leave the rest to Nolan. So the effective date, I guess it doesn't say anything about the report. The effective date, the act takes effect on passage.
So in all these dates and throughout the bill, we give them must be done by, but there's nothing that says that they can't do it now if they wanted to.
If they have the
They have the
ability to.
resources and the need to.
Right, I mean, some of these are reports and they have to report on or before a certain date. It would, hopefully they would not submit a report next week that says, we haven't started yet, that's our report for this year, but yes, they're always on or before dates. It gives some flexibility, but in reality, at least for reports, it's typically right around the
So things like, beginning with reference-based pricing as soon as practical, but not later than 2027.
that one is.
Is it practicable?
Yes, that one in
They could
particular,
start
that
it tomorrow.
that language is to encourage it to not wait until 2027, because that was the interest of
Okay.
the committee downstairs.
Okay. Tupper?
No, if you know.
Mm-hmm.
Go ahead. Something to do with reports.
Let's have Mari and then maybe it'll jog your memory.
I'm sorry to be going backwards, but on section 9, which starts on page 21, I've been looking at documents from witnesses in Senate Health and Welfare, and this one's from AHS, a fairly recent one. About retaining ACO capabilities. They said support striking this section. Work is underway with Green Mountain Care Board and One Care Vermont to maintain functionality. Do you remember the discussion about that and why it wasn't struck?
My general recollection is that there was still interest in sort of keeping track of that directive and having the report back in November. And if it was already happening, then great. They shouldn't be any,
No need to worry about it.
shouldn't be hard, yeah.
Okay. Thank you.
Tupper.
If I'm one of these people that has to make these reports and I'm not quite ready to make the report, what do I do? Just call up the chair of the committee and say, hey, I'm not ready to.
Yep, typically the agencies will reach out to the chairs of the committees of jurisdiction that are supposed to hear it and say, for, some reason, they'll usually provide some sort of reason. We're not going to be able to complete this until a later date. May we have an extension? And generally the chairs will grant that if it's reasonable. And sometimes those requests go up on the webpage as well.
Any other questions for Jen? I know that was a lot. Welcome to your next month, everybody. Nolan.
Thank you so much, Jen.
Thank you, Jen.
Thank you, Jen.
For the record, Bill Mangle, the Joint Fiscal Office. And my screen, this is the fiscal note. You should have a copy of it. As Jen mentioned, Bill, when it passed under health and welfare, had a bunch of positions and appropriations, Senate appropriations, stripped it out as sort of, I don't want to say tradition, but the former chair had done it, used to do that as well. Pull the appropriations out because there was a sense that one, they wanted the money to either be in the big bill or they want to think about it in the context of the overall budget as their budget context. So, so the bill, but they passed the bill. So, I assume that's a commitment to do something. Now, that said, so the appropriation that's in the bill and the needs that are in the bill may continue to evolve, not just on the Senate version as the two agencies that have the biggest impact, Green Mountain Care Board and AHS. AHS has already told me that the estimate that they provided to me for the Senate passed version has already evolved and changed. They think it would be different. Obviously, it's going to change based on what your needs are as well. But let me tell you what was in the bill stripped out. So there was 5 permanent exempt positions at the Green Mountain Care Board. There was a director of global budgets, a project manager for global budgets, a director of reference-based pricing, one project manager for reference-based pricing, and a staff attorney. There was also 2 new limited service positions at AHS. And this was a healthcare reform integration manager and 1 administrative services director. Total appropriations to AHS were roughly $1.8 million. 1.5 of that was general fund, and about 250,000 came from the Health Information Technology Fund. And that was for the data integration grants to providers. On the Green Mountain Care Board side, you had the positions, which were about 850,000. The contracts, they needed about $500,000 in contracts, and another $150,000 for standardization of electronic hospital budget data submissions. That's also from the HIT fund. So they had 1.3 million from general fund, 150,000 from HIT for a total of 150. I'm just throwing a lot of numbers at you. I know this, I'm sorry. But that's the gross numbers are in the fiscal note, which as I mentioned, there's 5, there's a total of 5 permanent positions, 2 limited service positions, 1.78 million to AHS, and 1.5 million to the Green Mountain Care Board. Now, again, the AHS number has evolved. It's not in the fiscal note and will continue to evolve as you shape the bill as well. But nonetheless, there is a cost in this bill to do the work. You'll need people. These agencies and departments will need resources that they do not have to do this work.
Can you remind us how many people at AHS they were anticipating?
2 limited service positions.
Limited service
Yes,
That's AHS?
that's AHS.
and 5 exempt.
No, so there's 2 limited services positions at AHS, and then the Green Mountain Care Board was 5 permanent exempt positions. So it's a total of 7 positions.
And 2 new limited service. So 7 to Green Mountain Care Board
No.
and 2.
5 to Green Mountain Care Board, full-time exempt. And then 2 to AHS, limited service, for a total of 7 total positions in the whole bill.
Sorry, I missed the age of, okay. Yeah,
I
Alan.
ask you what a limited position is.
Yeah, that's basically when you hire people on a specific basis. It might be a 2 or 3 year contract. So they're state employees, but their jobs are not permanent.
Okay, I thought, that's what I was thinking.
And so like, they don't go into the base.
Yeah, question, which of these, so these are going into the base? Some are, some aren't.
Permanent positions would go into the base.
So limited
Limited services positions would just be budgeted for those years.
year to year.
With all,
Yeah, go ahead.
with all these requirements and reports from the hospital, are the hospitals going to require additional personnel as well to do all this work for the Green Mountain Care Board? Where are they going to get? Are they going to get funding to help them?
What kind of reporting are they
I
supposed to
don't know,
do?
whatever the Green Mountain Care Board asks. to do.
They don't get money from the state to do their operations work
No,
now.
but it's a requirement that we're gonna be,
We have a lot of, we have a lot of requirements that we require of them now, and we don't give them the money to do it. Matter of fact, we charge them bill back to do the work for the Green Mountain Care Board to do their work. It becomes, to your point, it becomes an administrative expense.
So, okay, so there's two positions in the budget now.
5.
No, there's
Oh,
five
sorry,
here.
yeah, for the board, yes,
two-
correct. I think there's 3 in the budget.
There's 3 in the budget,
3 in the
and they
budget.
want 5 more.
For this bill, they say to do the work that's required of them in this bill, they need 5 people.
And then they're saying if a year and a half from now, if we go with a head model, Green Mountain Care Board's gonna need another what?
They were saying about 5 per year, but
Yeah.
I was gonna reference healthcare advocate, but I will not.
We will take testimony from the board and AHS on the, they feel.
I think to your point, we'll have to see what happens with the head model
Yep.
and assess those needs on a year-to-year basis in the context of the budget as we do every year anyway.
Guess my concern is, I read somewhere that there's $1 million there for one care that won't be used, right?
I'm sorry, $1 million for what?
Is it, okay, for, in the Green Mountain Care Board, they have access to $1 million? There's not being implemented on one care?
I'm
If it's
not,
ending?
I'm not,
Okay, and maybe it's not, but I was just wondering, yeah.
I don't think there's $1 million. I think that there was bill back, they may lose money from, but that's the whole bill back formula was to reallocate, but I don't.
But
I
the
don't think
point
about
was-
$1 million sitting on the bottom
Yeah.
line for them to do ACO work.
I guess the point I was getting at is how many people were working from Green Mountain Care Board on one care?
They had, the same people that were doing ACO work were doing hospital budgets, and
Okay,
they don't have enough people to do the work.
okay, so
as is,
definitely this is, okay.
As my understanding.
Well, definitely.
Good question. I understand what you're trying to get at, but there's not money laying around.
Okay.
This, not having to do the ACO regulations, which just kind of gets to the H63, was trying to reopen up work or reshift around resources for them to do a better job of the work that they have to do. Not a better job, but have the resources within the existing budgets to do the work that they already have to do.
Thank you.
The 1.78 from AHS, which I realize has changed since then. It's 2 limited service positions. What else was that including?
So there was 250 for hospital transformation grants. What I could do is I could let me pull up the fiscal note from as past Senate Health and Welfare. So give me a second here.
So the one that's on our committee website is not,
That's the one that's passed the Senate.
okay,
There's 3 versions. There's
okay.
passed the Senate Health and Welfare, passed Senate Appropriations, and then as passed by the Senate. So let me just let me pull this up, and this has that number, but again, this wasn't in the fiscal note given to you because it's no longer in the bill. But let me pull it up, and then I can send this to Kristen, or she can go to the JFO website. It's as passed Senate Health and Welfare. So this is the fiscal note for as passed Senate Health and Welfare. So you can see there's a breakdown. Let's see here. I have this chart, and you can see the breakdown. Let me blow this up. Cool. And you can see this is what they were saying they needed the money for. Now, the reason I think this has changed is when they first provided this to me, they were saying this is kind of what they were thinking they needed in the ahead model, and there was overlap. And then after the bill passed, they said, well, actually, we've put more thought into it, and we're kind of separating that from the ahead model and what the needs are, and who knows what's happening with the head model. So they said that it probably will cost more. They don't have a breakdown of it, but you could have them in and have them explain to you what they think they need to do the work. I haven't heard different from the Green Mountain Care Board in terms of the estimates, so.
Thank you. Any other questions? Right. Thanks, everyone. Long day. Off of live.
I understand.